Good afternoon. Can everyone hear me?
Yep.
Well, welcome. Good afternoon. So today's Geriatrics Core seminar lecture is a very timely topic filled with what I would call both emerging science and anxiety. But our goal today is to kind of discuss this clinical question of how long are COVID-19 patients contagious? And I have no actual potential conflict of interest in relation to this program or presentation, and ultimately opinions and/or conclusions presented are my own and do not represent any official VA statements. But I'd be remiss if I didn't mention this, that, due to our very challenging pandemic times, so today normally would be our scheduled Schwartz round gathering, but it was canceled. The fact is not lost on me. We all certainly need to take daily moments to safeguard our humanity in these trying times, as well as not to deprioritize or dismiss the more important problems in society. We all have an opportunity to take fewer things for granted now, especially our well-being of our fellow citizens. But in terms of our objectives for today, so first and foremost, to discuss the profound impact of COVID-19 on nursing homes in the United States. Secondly, to kind of discuss the time course and transmissibility evidence of how SARS-CoV-2, the virus that causes COVID-19, typically spreads. Thirdly, kind of discuss the role and pitfalls of waiting for a negative diagnostic swab for confirmation of recovery. Then lastly, to review the latest CDC guidance on this topic for discontinuation of transmission based on precautions of patients with COVID-19 in healthcare settings. That was last updated in April 30th. And as well, there's a VA memo from around that time as well, we shall review. So in terms of necessary background, so nursing homes are definitely taking the brunt of this, of the outbreaks. So the latest data, and this is from June 1st, nursing homes are accounting for 42% of America's COVID-19 fatalities. And honestly, that number is probably on the lower side. Several states in the gray here do not report such data. Other states like New York will report deaths, but don't necessarily report locations where they happen, meaning a nursing home patient, if they got transferred to the hospital and died there, that's not accounted for. So what's remarkable about this 42%, even more remarkable, is that only 0.6% of the total U.S. population live in nursing homes. But even as this chart this map will show, in some states the fatality is high as 65%, Minnesota leading the way, unfortunately. But it's a stunning statistic that has policymakers reconsidering their approach to fighting this pandemic. But speaking of New York in particular, so New York actually had a state governmental directive passed on March 25th to all New York State nursing homes, stating that no resident shall be denied readmission or admission to the nursing home solely based on confirmed or suspected COVID-19. Actually, I'm thankful for Dr. Geriatric, who shared with me this article probably mid-May from the Wall Street Journal, that always important medical journal. And the headline read, "New York sent recovering coronavirus patients to nursing homes," and that it was, quote, a fatal error. But what the time course did end up showing in New York is that the intent of this governmental directive was to free up hospital beds for the sickest patients as cases surged in hospitals. Anyhow, on May 10th, this directive in New York was reversed. In totality, during that time period, March 25th to May 10th, more than 5,800 nursing home COVID deaths in New York were reported eventually to have occurred in that period, which was more than any other state. So definitely a lesson for us all. In terms of the transmission overview, so in terms of understanding this topic fully, I think there has to be some discussion about just how exactly COVID-19 virus is transmitted. But kind of the key thing, kind of the overview, is that, for transmission to occur, so this rule holds true for this virus, let alone any respiratory virus, that successful infection equals exposure to virus times time. So it always is a balance of exposure and time. So if you get a high level of exposure, it's a short time to infection. If you get a low level of exposure, it's a longer time before infection can establish. So I included this acronym if there's going to be a discussion about perhaps why nursing homes taking the brunt of the outbreaks. Obviously, if you're in a nursing home, you likely have higher ADL dependency, meaning dressing, eating, ambulating, toileting, and hygiene. But to kind of continue with this simple formula, we kind of live this every day, meaning that, a short shopping trip would come with comparatively low risk of infection, but employees in that same store for an 8-hour shift will have a higher risk, meaning their exposure to the virus over a longer period of time is suspect. But in terms of the actual evidence kind of backing up such observations, so published epidemiology studies analyzing especially the early SNFs in nursing homes with COVID outbreaks in this country, in King County, Washington, had unfortunately strikingly similar prevalence rates of 60% of patients getting COVID-19, staff prevalence around 20%, and patient fatality around 25%. So in terms of pictures worth 1,000 words in many ways, but in terms of individuals are infectious when they are shedding a virus in their upper or lower respiratory tract. This shedding can be measured by doing nasopharyngeal swabs, then doing PCR tests to detect viral RNA, and we will talk in depth about some of the pitfalls of these tests for sure. So, but I think a key part before we go any farther is that a lot of determining getting a better answer to this question is kind of realizing some of these epidemiological or even basic science studies, just having the broader overview of the whole in vivo versus in vitro debate. So that's done many a times with a new drug in terms of efficacy in a lab versus actually in a human being. In many ways, this topic has similar pitfalls we should keep in mind. So one of the early studies that may gain headlines and as well as contributed significantly to the anxiety. So this was early May, a Chinese study actually trying to look at the efficacy of an HIV drug to see if it could treat severe COVID-19 patients. Ultimately, no effect was found, but it was not a wasteful endeavor. In terms of the interesting finding for our discussion today is that when patients were sampled for their swab viral loads, the researchers found that 65% were still shedding virus at day 28. So this cohort of patients, very sick patients that were in the ICU, but they found that 65% of these patients were still shedding virus at day 28. But even the authors mentioned that the implications of this shedding was quote unquote still to be determined. So this is actually the chart, one of the charts from that study, kind of showing that in pictorial form, that the control group was still shedding virus, many at day 28. So what does that mean for our discussion? So so for me, the whole in vivo versus in vitro debate, I think this study, which actually published earlier, but I think it has more real-world evidence for us to try to learn from. So this was more of an epidemiological study in the Journal of Nature Medicine, so initially published in April of 15th. So the title of it is probably a more detailed version of my talk's title, meaning Temporal Dynamics in Viral Shedding and Transmissibility of COVID-19. So basically, the researchers here try to report kind of the temporal patterns of viral shedding in 94 patients with laboratory confirmed COVID-19. Then what also is interesting, especially in terms of answer some of the more challenging aspects of this question, is that it actually, they attempted to model how COVID-19 infectiousness profiles from a separate sample of 77 infector-infectee transmission pairs. And we'll kind of go over exactly what that means and why that helps us answer our question. So this is a graph from that study, so kind of similar to that previous New England Journal study, viral shedding pattern in symptomatic patients with COVID-19. So in general, for those 94 patients, 21 days, some were still shedding. But the key thing about this graph is that we all will notice that the viral shedding, we can clearly see that viral shedding decreases after symptom onset, and that infectiousness as such would decrease with time. But what this curve does not mention is that what does the curve look like before someone has symptom onset, so before the first day of symptoms. So that's where the second part of the study, looking at the transmission pairs, can be very helpful for our discussion. So meaning if we're asking ourselves, what does this curve look like before symptoms start, meaning to the left of the curve, meaning when do a person start to be infectious, when is the peak of infectiousness, and when does a person no longer be infectious. So how best epidemiologically that can be determined, this meaning the left part of the curve, is to kind of studying transmission pairs, meaning look at who a person got the COVID from. So kind of in-depth contact tracing, to simplify it. So that's what this next busy graph shows. So the red dots are the original primary case, meaning the infector. The blue dots, and these are 77 pairs of these individuals. The blue dots is the onset of symptoms in that second case, meaning the infectee. And the green bars basically represent exposure window of transmission during which exposure must have occurred. So what the authors did, they did some sophisticated epidemiological analysis to see what pattern or curve fit this very busy data. And what they found is that and infectiousness, and kind of best showed on this next page, that infectiousness starts based on those 77 pairs of transmissions, started on average 2.3 days before symptom onset. So this vertical line is when person day 0 is when you started having symptoms. So infectiousness was starting 2.3 days before someone started having symptoms. Furthermore, what they found is that in terms of when someone is the most infectious, it was 0.7 days prior to their symptom onset. So what's particularly concerning about that, and different than what the medical world has faced, is that if you look at something equally scary at times, seasonal influenza, that your peak infectiousness is 1 day after you start having symptoms, meaning after you have the classic fevers or whatnot, usually 1 day afterwards when your peak of infectiousness in terms of viral loads versus COVID-19, for whatever reason, it's actually almost 1 day before onset of symptoms that your infectiousness is at its peak. But what was more reassuring and helped us with our current clinical question is they also noted in their analysis that almost no more infectiousness after 7 days of symptom onset. So that's something very similar to influenza as well. But that combined with kind of this overall analysis, they basically have found that 44% of those infections occurred in that pre-symptomatic phase. So that's very much sometimes a difficult thing to ascertain, is someone pre-symptomatic or asymptomatic. So this particular study was looking at individuals who had symptoms, and what they found is that 44% of the time the infections for that secondary person were occurring when the primary person, the infector, was asymptomatic, so was at that time pre-symptomatic, so 44% of the time. So that's a very scary picture for us to kind of ponder. But the other important thing about coronavirus, which ultimately we just do not know, is that does the amount of coronavirus you are exposed to determine how sick you will get. So we know from other diseases that the dose of a virus a person is exposed to will directly correlate with how severe a case he or she will get. So influenza is a well-known example of this. So there've been many studies. There's one from 2015 that's well cited, that the higher the dose of flu virus given to a healthy volunteer, the worse their symptoms were. So does that also apply to this respiratory virus, SARS-CoV-2? So ultimately, like I mentioned, we do not know. The only way definitively to answer that question would be similar experimental challenge studies, which would be very ethically questionable because of the severity of COVID-19 in certain individuals. So that's something that would have helped answer the clinical question, but we do not know. But in terms of an important thing to keep in mind as we looked at those curves and viral loads and things along those lines, it's important to bear in mind that the amount of virus it takes to cause an infection is only part of the story. So how a body responds to the virus is also very, very critical. This is because the immune response to a virus can be both beneficial and harmful. So if the immune system isn't adequately activated, the virus can replicate faster. On the other hand, if the immune system is overactivated, it can damage healthy tissues. So this obviously kind of the key part of our question is, when can someone be off of our COVID isolation? So typical COVID isolation is both droplet and airborne, meaning gown, gloves, mask, eye protection, and the N95 respirator. So kind of to summarize what the clinical question we're asking, when can a inpatient be off of this and more to their standard precautions, which in the COVID era would still involve social distancing and PPEs for anticipated exposure, gloves, mask, and gown. So fortunately, there is CDC guidance now for discontinuation of transmission-based precautions of patients with COVID-19 healthcare settings. So the key thing here is that the recommendations are different for symptomatic versus asymptomatic patients. So this was last updated in April 30th. Just overall, the guidelines, which are a one-page document, kind of offer symptom-based, test-based, or time-based strategies. So this is kind of the wording of those guidelines. So we'll start with the symptomatic patients. So I'll kind of go over it point by point, but this is, ultimately directly answers our posed question. So symptomatic patients with COVID-19 should remain in transmission-based precautions until either, this is the symptom-based strategy. So at least 3 days have passed since recovery, defined as resolution of fever without use of fever-reducing medications, and improvement in respiratory symptoms, cough, shortness of breath, and at least 10 days have passed since symptoms first appeared. So that's the symptom-based strategy, meaning individual got tested, then clinically you observe their symptoms as fever improving for 3 days, and respiratory symptoms improving as well as 10 days passing. So minimally 10 days. So the test-based strategy, and this is the one that, logically we would want to have an easy answer for, but we'll get to this later. But this has many, many pitfalls and not as ideal as one would hope. So meaning this strategy would be resolution of fever without the use of fever-reducing medications still, as well as the aforementioned improvement in respiratory symptoms, and negative results of a FDA emergency use authorized COVID-19 molecular assay for detection of SARS-CoV-2 from at least 2 consecutive respiratory specimens collected more than 24 hours apart. So meaning stay in isolation until you've had 2 negative swabs 24 hours apart. So there's several key words that we'll kind of expound on later. The emergency use of this test, meaning how valid is the test, and also why are 2 required. So we'll kind of get to the evidence why 2 would still be required for such a thing. But the key thing, even the guideline wording mentions that of note, there have been reports of prolonged detection of RNA without direct correlation to viral culture. So we'll get to that more later. But just to finish the other end of the guidelines, these are for asymptomatic patients. And trust me, I've had, since our COVID started here at Hines, I've had many a discussion with many a clinician about what really does asymptomatic mean. But patients with laboratory confirmed COVID-19 who have not had any symptoms should remain in transmission-based precautions until either a time-based strategy, so similar to the previous slide, 10 days have passed since the date of their first positive COVID-19 diagnostic test, assuming they have not subsequently developed symptoms since their first positive test. The guidelines note that because symptoms cannot be used to gauge when these individuals are in where they are in the course of their illness, it is possible that the duration of viral shedding could be longer or shorter than 10 days after the first positive test. So that's why the test-based strategy is listed as well, meaning this is very similar to consecutive respiratory specimens collected more than 24 hours apart. Again, because of the absence of symptoms in this cohort of patients, it's impossible to gauge whether these individuals are in the course of the illness. And again, the guidelines mention that there are reports of prolonged detection of RNA without direct correlation to viral culture. But the key thing, and we'll get to this on the next few slides, is that detecting viral RNA via these very, very, very sensitive PCRs at times does not necessarily mean that an infectious virus is present. And the epidemiological data kind of reinforces this. But ultimately, the guidelines even mention that sometimes these are not easy questions to answer, that consulting with local infectious disease experts when making decisions about discontinuing of these precautions, especially for patients who might not be reading the textbook, as they say, and remaining infectious longer than 10 days, or the severely immunocompromised patients. But outside of these CDC guidelines, we are fortunate that we have some added VA input on this topic. So a VHA memo from end of May 29th, basically recommends following those CDC guidelines we went over in detail, but they had kind of two added pieces of advice, number 4 and 5 here. So number 4, the wording says that VHA recommends that for symptomatic patients, kind of recommending the test-based strategy should be considered if the timing of the symptom onset is unclear, when there is prompt clinical recovery. So for symptomatic patients, it's kind of recommending the test-based strategy, especially if someone's immunocompromised. Otherwise, symptom-based strategy is preferred. So rather than kind of just listing those two strategies, kind of the VA memos, the wording of it seems to don't use the word favor, but should be considered the test-based strategy for symptomatic patients. For asymptomatic patients, the test-based strategy as well should be considered if patients are severely immunocompromised. Otherwise, so meaning for asymptomatic, they're saying if you're immunocompromised, then the two tests is what they would kind of recommend. If not, if someone is not severely immunocompromised, then the time-based strategy is preferred. So kind of doesn't really add clarity, but it definitely is something. But in terms of some more evidence about why those days and recommendations might be, so the further epidemiological evidence is kind of showing that the SARS-CoV-2 virus has an incubation time, and that means time from exposure to development of symptoms kind of varies between 2 to 14 days. The median time of exposure from symptom onset is 4.5 days. Even some of the previous graphs we already discovered kind of confirmed that as well. But this is the key thing from emerging research, is that almost 98% of persons with COVID-19 who develop symptoms will do so within 14.5 days of infection. So meaning the whole logic of the 10 days of precautions is in many ways based on this, meaning a vast majority of individuals are, if you're going to show symptoms, are doing it within 14 days, if you want to be conservative about it, but 11.5 days as well. That's some of the logic behind the 14-day quarantine recommendations, which have been kind of at the Hines campus for geriatric patients, at least. But there's many pitfalls. So this graph actually, it's amazing how life can be opportune. But yesterday I literally met two vets who here on campus on the COVID floor who they're kind of doing this. They literally have gotten tested positive for COVID more than 30 days ago. One vet was, for whatever reason in life, he's gotten 5 tests in less than a month, and he literally would be positive. The next one they do on him is negative. Then the next one's positive, the next one's negative, and he's getting another one today. So what some of the evidence is showing is that for whatever reason, the viral load, which we already kind of talked about, in some individuals, rather than going all the way down to 0 at that 2 to 4 week mark, that there's these what researchers are calling blips, a small amount of increased viral load that's detected, sometimes even months later. And this, sounds scary or strange, but influenza has a similar noted curve as well. So the real clinical question is that what to make of this. Are these individuals, are the reported cases of these individuals with these blips infecting others? I think that's the more in vivo or real world evidence that helps kind of answer a question, because obviously, on paper, this would mean, oh, this individual would need isolation for months and months and months, but even with clinical resolution of symptoms. But we'll get to more of this later, but this is kind of interesting term called the blips. But kind of further evidence about the symptom-based strategy of discontinuing isolation. So there's a May 23rd study out of Singapore in which they tested 73 COVID-19 patients. So on average, they found that the virus could not be isolated or cultured after 11 days of onset of illness. So this was true despite viral RNA being detected with PCR tests. So this previous graph, these are viral PCR tests, but in terms of actual viral culture, which is ideally would be your gold standard way of detecting active virus that's able to infect other cells still, they found of these 73 patients that no viral culture would grow despite the PCR swabs being positive. So their conclusion was that viral RNA detection by PCR does not equate to infectious or viable virus. So there's plenty of hypotheses in terms of just fragments of RNA, and the tests are sensitive enough that they're picking up just a fragment, as well as discussions about different type of cells in the body will clear the virus sooner than others, meaning upper respiratory versus lower respiratory versus sputum. So there's plenty of things that ultimately, for me, this is the whole in vitro versus in vivo discussion that kind of is more reassuring that despite people swabbing positive more than 11 days, they're not able to have active virus cultured, which ultimately is kind of more, in theory, in vivo evidence that they're no longer contagious after 11 days, even though their swabs are still positive. But in terms of even more favor of ignoring those blips and maybe not reswabbing to confirm cure. So this also another recently published study out of Korea, a larger study, looked at 285 COVID-19 patients who, just like that vet I mentioned a moment ago, who tested positive, then negative, then positive again. So kind of unfortunately a blip after blip after blip. So these patients were repositive anywhere between 8 and 82 days after initial onset of symptoms. So the researchers similarly used coronavirus samples collected in nasal swabs and found that none of them grew in culture. So kind of a larger study of 285, kind of confirming that same thing with that smaller study on the previous slide. So the suggestion is that the virus is dead, meaning a fragment that's not active anymore. Furthermore, as added proof of this, they checked the blood from a small subset of these patients and found that most had neutralizing antibodies, kind of potentially more evidence of exposure and a resolution. But because of the study, the Korean CDC, they actually lifted the requirements that people recovering from a COVID infection have to have a negative swab before they can return to work or school. So they actually changed their official terminology. Before, these patients were called repositive patients. They changed that term to PCR redetected after discharge from isolation. So one of my secret medical hobbies is guessing medical abbreviations. So should we call this group PRADI? That's kind of the respiratory isolation in particular, but in terms of the COVID isolation, obviously it's more than just respiratory, it's your contact isolation as well. So what evidence is there that it is okay to stop that after a certain date? So more and more research, and even if you look at our own habits, trust me, people are not panicked about wiping down all their groceries to the extent they did maybe back in March. And some of it is that the evidence is showing that respiratory spread versus contact spread. So this is actually a soon-to-be published study coming from Germany, but they basically sought to investigate just that question, the role of environmental transmission of SARS-CoV-2. So basically they looked for traces of the virus in 21 households that each include at least one actively infected person. So homes in which someone was residing who had active COVID-19. So they swabbed many surfaces in the homes and found that viral RNA in just 3% of samples from the most frequently touched objects, such as doorknobs, and 15% of samples taken from bathroom drains and toilets. So what's that? Sounds still significant, but again, just like those previous studies, they found that just those samples, they were not able to grow the infectious virus from any of those samples, meaning the viral cultures were negative. So the author's conclusion, and again, this is a pre-publication, that the findings suggest that direct transmission of the coronavirus through exhaled or cough droplets is probably the main route of infection rather than contact. So kind of more evidence that, at some point, the risk of contact spread of COVID-19 might be overstated. But this is kind of a key thing that I think is being left out of this whole debate or pandemic management, is that how reliable are these swab tests? So this also is technically, I think, pre-publication. The printing version should be out this week, I believe, from the New England Journal, from researchers from New Hampshire as well as Harvard. Kind of more of a editorial or letter, kind of analyzing kind of just the pitfalls of these tests. So like I mentioned, while the debate has focused on the accuracy of antibody tests, which can signify a prior infection, diagnostic testing, meaning the nasopharyngeal swabs, that's receiving less attention. So ultimately, given the rapid nature of this pandemic, the FDA granted emergency use authorizations to the commercial tests and manufacturers, and quote unquote issued guidance on test validation. So in many ways, the bar was lowered in many ways, and that's what these researchers were trying to analyze, is really how accurate are these tests. So what they found is that normally the FDA, for any type of test of this, would prefer natural clinical specimens, but due to the emergent nature to have testing onto the market, they permitted the use of contrived specimens, meaning kind of artificially created viral RNA for testing purposes. Furthermore, this was particularly interesting to me is that obviously much in the news, and even yesterday the WHO had a statement and about the asymptomatic risks, and maybe that was walked back today. But all of the tests on the market, the assessment of the sensitivity in asymptomatic people had not been reported for any commercial tests as of June 1st, 2020. Meaning these tests were never tested in terms of how accurate they are in asymptomatic people. And there's more of a epidemiological or basic science study about if you're asymptomatic, do you have less viral loads? And there's some evidence towards that. Others, that's kind of more murky, but ultimately these tests were not validated for asymptomatic people. Then ultimately what these authors further did is they did a systematic review of 5 studies involving, let's say, almost 1,000 patients, and they found that the false negative rates range between 2 to 29%. So not an insignificant number, especially when you're getting to the 29% part. So overall, the authors' conclusions were that the current PCR swab tests are imperfect, that just like we do with other medical tests, such as a stress test for someone who has a chest pain, we need to keep in mind the pre-test probability of a person's chances of being infected, and to keep a high degree of suspicion if a patient has symptoms or exposure history. So trust me, anecdotally, I've seen many a time where there's been a high degree of suspicion about someone who had a known contact or a roommate that was COVID positive, and that person, despite the initial negative swab, was still spiking fevers, and there'd be more and more swabs just about with every temperature spike, it seemed like. But that's kind of the spirit that the authors are recommending, is that keep in mind pretest probability, and that just if someone's negative but still having symptoms with no other explanation, keeping a high degree of suspicion, even though CDC guidelines kind of allude to this about the need for 2 negative tests. It's kind of more evidence about that, and meaning just how accurate are these tests. But what the authors further concluded is that based on their analysis of those 5 studies, they said the sensitivities for many available tests suggest that 70% sensitivity is a reasonable estimate. So in medicine, we're just not used to that, being that low in general. But again, it kind of more reasons to kind of do a pre-test analysis before you order a COVID test. But they further state that there's still a need for tests that are highly sensitive, and that, quote, negative results cannot rule out an infection if the pretest probability is high, so clinicians should not trust unexpected negative results. Furthermore, there's a need to assume that a negative result is a false negative in a person with typical COVID symptoms and known exposure. So 70% sensitivity makes this statement, very much appropriate. But performing several simultaneous or repeated tests could overcome a test-limited sensitivity. So kind of more reasons to kind of respect that test-based guidelines from the CDC about the 2 swabs for certain individuals. But we definitely kind of presented a lot, but ultimately, for our purposes, kind of my personal conclusions on this topic, and I definitely wanted to leave time for questions. So first, I would conclude that, a COVID positive swab doesn't mean that a patient is still sick or contagious after a certain time period, 11 days, or do you want to say 14 days, but after a certain time period, just a positive swab is just that blip on that chart, most likely. Furthermore, much evidence now is coming out about the faultiness of these RNA swabs, and that this should not be held as the gold standard of COVID-19 outcome success. For me, the viral culture evidence for such patients is kind of makes that very much a valid statement. Furthermore, the severity of symptoms does have implications as to the likely recovery period, meaning that severe COVID-positive patient who need an ICU stay should err on the side of a longer quarantine than that mildly symptomatic or asymptomatic person. And then the CDC guidelines, I would say, provide a good framework for clinical decision making, but again, err on the side of being more stringent precautions when in doubt. And then furthermore, and especially here, as you know, this is kind of, I say, the good stress as you try to evaluate patients to come off COVID isolation, especially when you talk about, are you symptomatic? When did your fever resolve? When did your respiratory symptoms improve? It should not be as simple as just, discontinuing that nursing text order to stop the isolation. That I would advise just to be thorough about it and prevent any, mishaps or missteps. Clearly and concisely written documentation, maybe a CPRS template might be needed for the removal of COVID isolation, just to document the important criteria to do it appropriately. Then the last thing is that staying safe isn't just about hygiene and distance; it's about time of exposure too. So especially if you want to be concerned whether a person has some still active virus far away from their initial swab, it's not just the standard precautions, but also the time of exposure as well. So that's something to keep in mind, especially when we're dealing with a patient with high ADL needs and how much time is a person's needed to be in that room and so on and so forth. It's kind of key things just to keep us all with kind of murky data, but I think that's an important thing as well. I think we do have time for questions. I think how can I best do this? So I think I did mute the mics if anyone has a mic, and then I'll have to see about the number of questions. So it looks like I was popular. So actually, Dr. Gorbian has a question.
Salman, that was brilliant. Thank you very much. As we can all see, there is much complexity and much that we don't know. So much of what we have learned in our learning comes from the lay press. Washington Post, New York Times. New York Times has done an excellent job of reporting, and I shared an article today that talks about in New York State, the governor was recommending that all nursing home residents and nursing home workers be tested twice a week. So there are at times recommendations that don't match what the CDC is saying, and there's a big discussion around this. And really the article was more about the cost. But in the end, local hospitals and nursing homes, of course, have to be allowed to use their own common sense. Then there was another breaking news that came out during your talk. This is going to be shocking for everyone. They're talking about the second wave in states that have opened up and states that are opening up too quickly. And of course, that's not a surprise at all. So the community spread will remain a large an important deal for some time to come.
Thank you, Dr. Gorbian. So very much so, and I think there's some excellent written questions I'm going to address as well. So Dr. Mantha is asking if infectiousness ends around 7 days of symptom onset, why does the symptom-based strategy from the CDC recommend 10 days? So different data or abundance of caution? So I would say abundance of caution. So 7 days, 10 days, 14 days, and even our ID service here is kind of working on maybe some more specific guidelines for our Hines campus about even longer precautions for patients after inpatient discharge. But that's the best way I would answer that to err on the side of caution. Especially when we're talking about people coming to some place like a nursing home where very highly vulnerable patient population for sure. Then another question here, just FYI, I work in home telehealth, and I think I muted everyone's mics. If everyone please can still keep their mics muted. But I work in home telehealth. We covered COVID patients who were exposed, had clinical symptoms, and tested positive. Have found a few who had multiple testings were positive as for as long as 6 weeks, yet asymptomatic. Not sure if this RNA test has been interesting to find. Yep, kind of that. I think the whole blip, the blip graph definitely fits the picture, and many times, and trust me, it's having impact on returning to life, let alone getting medical tests done. And trust me, there's a vet in the hospital that's awaiting a procedure, and every other day he's positive and negative, and they want two negative after 30 days of his initial swab. And I can only imagine what it's like to be NPO and it gets canceled, and they test him 2 days later and it's negative, and then they wait for the next one, he's NPO and it's positive, and so on and so forth. So kind of more reasons to kind of embrace the challenge of this clinical question, and kind of have a good understanding of the evidence, and to make kind of the best thing for patient care to continue. So Dr. Lavery is asking, so how do we spread the message to providers, staff to not keep insisting on repeat COVID testing on patients that are 2 weeks, 4 weeks, 6 weeks out from initial positive tests? So it's not changing management. So kind of the reason why I volunteered for this talk. Trust me, there's I think a lot of it's, we need to discuss these things more, but I think that's I think they're, especially even with the patients who need procedures, and we all need to be on the same page. That much I agree for sure. So Shireen is asking, what is the recommendation from CDC for retesting for LTC and staff, especially with so many cases of positive patients and staff? So the CDC does not have recommendations for that at all, in terms of, someone who's not an inpatient isn't the vulnerable patient population, but it's the same, like I said, looking for symptoms, and we're very fortunate when you walk in the door to have that screening in place. Our rate is low compared to patients, so that's not part of the recommendation of the CDC. Then Dr. LeMay is mentioning, thanks for clarifying the types of precautions, contact universal, etc. How can GERI providers access eye protection? So believe it or not, I saw a large amount of them here in our building. So I think that's an important thing. And that's, trust me, that could be a lecture on its own, the value of eye protection and the role of it. But yes, and some of it, especially when, you look at, I think, the medical community or society at large will be analyzing 2020 in many ways, but just, was aggressive prevention put in the right places? But we do have goggles and shields. Trust me, I've seen people with them on, but I think that's an important thing that we all make part of our daily practice, of course. Then Dr. Bial is asking, do we have any data on number of people who have been turned away by our screeners due to temperature? I don't know. I hear it anecdotally, but I don't know. That'd be actually next time I'm downstairs, I might ask. And Candy is mentioning that we have lots of face shields in my office, and can get more goggles. So thank you, Candy, for being the distributor of all important things. But any other questions at all? So, Dr. Shashila had a question. Oh, I missed your question. I'm sorry. I scrolled. I didn't realize the things were higher. They were doing this. Fair enough. Had a question above mine. Oh, I'm sorry. Oh, I see it. I'm sorry. My vision's not, I missed it. So so Dr. Sushila is asking, does the test being negative have to be the same type? Does it make any difference if the test is rapid, Cepheid and BD Max versus Quest? So that's I'll have to kind of defer that one in terms of ultimately, the more rapid tests, or the evidence is not as good as the more viral PCR send out type tests, but ultimately the CDC does not differentiate what type of tests. That's the best way I can answer that. But like I said, this is definitely an important topic for us all, and then ultimately this is probably a great situation where it's each case will be on an individual basis. I don't think there could be a universal. I think once upon a time, the yellow thing in CPRS, you're positive, is supposed to expire after 14 days, and I don't think it can be that simple. That each case has to be analyzed on an individual basis, but it has to be analyzed. It can't just be myopic procrastination on this clinical question. I think is not going to be conducive to us getting back to normalcy. One more question, Dr. Gorbian.
So I just wanted to mention, many of you are probably wondering when visitors will be allowed in CLCs, and most of the decisions, if not all of the decisions that have been made at a national level, really mimic the CDC recommendations, and nursing homes across the country continue to be on lockdown. Of course, this has a big emotional toll on our patients, as we know, but once that rule is loosened and there is no hint as to when that may be, but of course, that will change the equation dramatically, because we have things under such tight control, the tightest control that is possible, but that will change everything.
All right, good deal. So a couple additional questions. So how long does the patient need to be on droplet isolation or quarantine when admitted to the CLC from acute care? Do we still follow the 14-day guideline from initial Hines hospital admission? So I can say yes, that's what I am continuing to do. Yes. Well, and trust me, you all have my email address. Actually, I've gotten, trust me, I've given many a talk, and I've never seen so many requests for me to answer questions. And I'm not going to pretend I have all the answers, but I think this discussion is kind of an overdue and helpful thing. And trust me, especially when we had our long-term care vets who were COVID positive return to their home. I was very proud of how we all handled it, and I can only imagine what it's like to have been stuck in an isolation room for so long. But this is, I say, is the good stress that you have a geriatric age person to survive their bout with COVID, that getting them back home or to their families at home or back to their nursing home, I think is something definitely to be celebrated as where we are in our progression in this disease. But thank you all for the kind words. So you all know where to find me, so don't hesitate to stay in touch. And then I have to thank Jennifer, our program secretary, that there was such a demand for this talk that even later this afternoon, she's planning to upload it onto our Geriatric Fellowship Twitter account. So please do spread the word. And it's a new account. I think we only have 4 followers. So it'd be a great place for a continued discussion. So please do follow us there, and we continue the discussion online and obviously in the hallways as well. So thank you all so much.